Hopefully people can see me. I've just unmuted my video, so hopefully you can just see me as I'm presenting and sort of facilitating today's session. So I'm delighted today to say we have two excellent presenters, knowledgeable presenters on the AMPAC, who are going to impart their knowledge with us today. First of all, we have Dr. Jette. Alan's research focuses on the evaluation of rehabilitation outcomes, functional measurements, and the prevention and treatment of disability. He served as Dean of Boston University's Sargent College of Health and Rehabilitation Sciences from 1996 to 2004, and was Professor of Health Policy and Management at Boston University School of Public Health from 2005 to 2017. He currently serves as Professor of Rehabilitation Sciences at the MGH Institute of Health Sciences, and in 2013, Dr. Jette was elected to the National Academy of Medicine, which was formerly the Institute of Medicine. He is currently Editor-in-Chief of the Physical Therapy Journal. Joining Dr. Jette today is Annette Lavezza, and I hope I've pronounced Annette's surname correctly. Annette, when you speak, please correct me if I'm wrong, but I have Annette Lavezza. Annette is an occupational therapist with 28 years of experience as an occupational therapist. She is currently the Acute Care Adult Therapy Services Manager at Johns Hopkins Hospital, directing physical therapists, occupational therapists, and speech and language pathologists. She specialized in occupational therapy for patients with neurologic impairments and leverages her years of experience as an occupational therapist by engaging in transdisciplinary quality improvement projects, including integration of activity and mobility promotion as a standard of care and deployment of acute rehabilitation intensive services for targeted populations. And I am Shelley Hughes. I'm an occupational therapist and Senior Product Manager with Pearson Clinical Assessment. I've been qualified as an occupational therapist for 26 years and currently registered as an occupational therapist in the UK, but previously worked and was registered and licensed in the United States, where I worked in the US school system in Florida. I manage the occupational therapy and developmental portfolios internationally with Pearson Clinical Assessment. So I've sort of rushed through those introductions, but I'm going to quickly move on to the process for continuing education credits. For those of you who wish to apply for continuing education credits, we have approval to provide these for AOTA. So on your screen, you will see the directions. These are also in your handout. We will provide continuing education certificate if you attend the full 60 minutes of the live session. If there's more than one of you at your site, please complete the attendance sheet, which is downloadable from the platform here, and please complete the evaluation form, and you must email these back. Please don't take a photograph of them, but email the PDFs back no later than the 11th of December. They go to my colleague, Darlene Davis, and her details are on the screen and in your handouts too. Pearson will not provide attendees for certificate if they if you're watching this after the live session. So we'll only provide it for the live session. For physical therapists, because I imagine there will be some physical therapists on today's session as well, you can get a certificate of attendance. We don't have approval to provide formalized continuing education credits, but you can get a certificate of attendance for today's session as well by completing the same documents. In terms of disclosure information, I'm not going to read all this out. You have this in your handouts, and it's on the registration documents as well. In terms of learner outcomes, I will quickly mention that today's session is around understanding and describing how AMPAC uses the conceptual framework of the ICF from the World Health Organization's International Classification of Functioning and Disability, and how that relates to the AMPAC. We're going to cover explanation of why converting a raw AMPAC score to a T-score is useful, how AMPAC is administered in the acute care setting, and the utilization of AMPAC scores for care and discharge planning in the acute care setting. So on that note, here's your agenda, which again is in your handouts. I've taken up quite a lot for introduction, so I'm going to pass you on to Dr. Jette, who is going to be our first speaker. So I'll turn my video off and pass you on to Dr. Jette.
Thank you, Shelley. I appreciate the opportunity to present today and to talk about the development of the AM-PAC instrument. We did this work at Boston University back in the early 2000s, and we set out to develop a functional outcome measure that would meet several criteria that we thought were important. First, we wanted it to be an instrument that could be used across different types of patient conditions, and we focused on the major ones: musculoskeletal, neurologic, and major medical conditions. We also were interested in developing an instrument that could be used across different care settings so that you could monitor the function of your patients across an entire episode of care and not have to change your metric for looking at function as the patient went from one care setting to another. We designed it so it could be administered through patient report or clinician/family proxy report. We designed it so that it could be used to look at clinically meaningful change. And then lastly, but also very importantly, we wanted it to be practical so it could be used very widely. So those were our goals, which were very ambitious. Now, to do that, we decided to use an approach to measurement referred to as item response theory, which is quite different than the more traditional methods for looking at measurement in clinical settings. When you do IRT development, you select items that go into your instrument very carefully so that they cover the full range, in this case, of function, from very low functioning to very high functioning. And so you select each item very carefully. You end up with a group of items in the pool that provide different information about function, and we calibrate each item so we know the level of difficulty of that item relative to every other item in the pool. And then the scores for a given patient are based on probability models that represent the likelihood that a person would give a specific response given their level of function and the difficulty of the item. And this is quite different than what you would see in a traditional instrument. Now, for the AM-PAC, we ended up with 3 distinct domains of function that we focused on: basic mobility function, daily activity function, and then what we called applied cognitive functioning. In developing the instrument, we developed quantitative scales for each of those 3 functional domains. And so the AM-PAC, in essence, consists of 3 different scales, and they're quantitative, and they focus either on how difficult it is for a patient to do a set of activities or how much assistance or help they require to do the set of activities. We developed the instrument and validated it on a sample of patients who were receiving care, acute all the way through post-acute care. We had over 1,000 patients in our development sample, and they received care in inpatient rehab, skilled nursing facilities, long-term acute care institutions, home health, and outpatient. So across the full range of care settings. This is a graph that kind of illustrates how the AM-PAC breaks out in the 3 domains of functioning. In the area of basic mobility, we focus on tasks such as ambulation, transfers, bending, carrying, lifting, locomotion with a wheelchair. We have over 100 items in the basic mobility scale. In the daily activity scale, which focuses on both ADL and IADL, we have about 90 items. In the applied cognition scale, which focuses on communication, use of print information, and following complex instructions, we have about 50 items. So you can see we have a very extensive group of items that cover the full range of functioning in each of these three domains. Now, we have some of the items focus on how much help an individual uses in order to do the activity. And so in the help scale, you would select total if the patient requires total assistance or cannot do the activity. You would select a lot if they use maximum to moderate assistance, a little if they require supervision or minimal assistance, and then finally, no assistance. And the higher the score, the better the functioning of the patient. In the difficulty items, you would select unable if the patient is not able to do the activity or can only perform the activity with assistance. You would select a lot of difficulty if the patient can do the activity without assistance, but requires a lot of effort or time. You would select a little difficulty if the patient can do the activity without assistance, but requires a little more time or effort, and then finally no difficulty. And again, the higher the score, the higher the functioning. Now, as I mentioned before, the administration of the AM-PAC is flexible. It can be done using patient self-report or proxy report. If the patient is in a care institution, we use the clinician as the proxy. If they're in the home, in the community, the family member we have found is the best proxy. The AM-PAC instrument can be administered in two ways, using a technique called computerized adaptive testing, or CAT, or short forms. I'll briefly describe each. A computerized adaptive test gives you the ability to administer the instrument using a computer device, and the algorithm in the computer that we have written will select a small number of items from the large pool of items and administer each of those items to a particular patient or the clinician. The items that are administered are chosen based on how a person responds to the previous item. So that's what the computerized algorithm does. It selects the best item based on a person's response to previous items. Testing stops when a person's functional level is estimated with a given level of precision. So for example, in the mobility scale, you have over 100 items, but using a computerized adaptive test, you might administer only 6 of the 100 to get a precise score. This is what allows one to adapt the AM-PAC to patients in different care settings and across a wide range of levels of functioning. Now, an alternative method that many people use is what we refer to as the AM-PAC short forms. And here we have pre-selected items from the large AM-PAC pool that best fit a particular patient population, typically based on setting. So we've developed a suite of short forms. One, which is very widely used, is our acute care short form, or some refer to it as 6 clicks. But we have other short forms, for example, outpatient short forms, community mobility short forms, home health short forms, and then low functioning, very low functioning acute care short forms. Each consists of a small selection of items that were selected from the larger pool that best fit the particular patient population. Here's an illustration of the basic mobility inpatient short form that consists of 6 items. And you can see the scale. This is a help scale from total to no assistance, and there's a numeric value for each response to each item. This is an illustration of the daily activity inpatient short form. And we have a whole suite of these short forms. This is an illustration of the applied cognitive inpatient short form. And you can see on this form, the items focus on how much difficulty the patient currently has, not the amount of help. Now, let me briefly talk about scoring the AM-PAC. For each of the short forms, you can basically obtain a raw score by summing the scores associated with each response to each item in the short form. And then what we do is we convert the raw scores to a standard Z-score. And the Z-score takes the raw score and puts it in units of standard deviation. That way you can look at the degree to which a given raw score is above or below the mean based on a normal distribution that we calculated off of our development sample. In a Z-score, the mean is 0 and a standard deviation is plus or minus 1. Now, to make it easier to interpret the standard score, we have converted the Z-scores to T-scores. And to do that, we basically multiply the Z-score by 10 and add 50 to your answer. So for example, a Z-score of 0.5 would be multiplied by 10 equals 5, and then add 50, which gives you a T-score of 55. And so the mean of the distribution of T-scores is 50, and a standard deviation is plus or minus 10. And that's how you go about going from raw scores to standard scores. Now, the beauty of the standard scores, it allows you to compare scores from one short form to another within a particular domain. So if you're using a inpatient mobility short form, you calculate a T-score and you can compare it to the T-score for mobility in outpatient or home care, and it's on the exact same metric. And that's what allows you to use AM-PAC short forms to look at functional change across an entire episode of care by converting your raw scores to standard scores. Here's an example of a simple table for each short form. We've put together conversion tables so you can see on the far left column the AM-PAC raw score. In this example for basic mobility inpatient short form, it converts it to the T-scale score and then the standard error. So an AM-PAC raw score of 6 on this particular short form converts to a T-scale score of 16.59, where the mean would be 50 plus or minus 10 standard deviation. So in summary, the AM-PAC covers 3 domains of function. It uses IRT measurement methods in order to achieve both breadth and precision, flexible administration, and can be used to assess patients across multiple settings. Thank you. I'll now turn it over to Annette.
Good morning, and thank you for joining. So in my section, we're going to discuss the inpatient short forms. I'm going to spend time talking about specifically deployment of the inpatient 6-clicks forms. Based on our experience in deploying these across the institution, I'll share with you some of the challenges and pitfalls, as well as the frequently asked questions that came up during our deployment. So let's start with talking about why it's important to think about education and training as we talk about the deployment of the inpatient short forms. In order to reap the benefits that Dr. Jette has talked to us about with the AMPAC and being able to compare it across settings, we need to ensure that when it is scored, we are following consistent interpretation of the scores, as well as consistent scoring of the form. And so some of that information is contained in the short form manuals, and some of it is through education with your staff. So we'll start when we talk about the inpatient short forms. Dr. Jette has talked about how the lead-in question is important, and it is critically important when you're talking about deploying the AMPAC short forms. The daily activity and mobility short forms both start with the lead-in question of how much help from another person do you currently need? It's important that this question is a help question. How much help do you need? The applied cognitive short form starts with the question of how much difficulty does the patient currently have? So in answering the question, you cannot just read the descriptor of the activity. You need to understand whether you're looking at help or you're looking at difficulty, because that influences your choice of answer. It also influences the answer. So let's talk a little bit more about this idea of how much help from another person do you currently need? This question does not specify whether it's physical or verbal assistance, help. So in our facility, what we have talked about is that help is both physical and verbal assistance. You need help to perform the activity. Therefore, regardless of that assistance being physical or verbal, that should influence the scoring. And so that's an important piece to remember as you're training staff and working through this tool. Dr. Jette talked about this already, but in the inpatient short forms, items can be scored by the patient or patient proxy. But in the inpatient acute care setting, that proxy is the clinician. And let's talk a little bit about how we score the tool itself. So the AMPAC is a capacity tool. We are using all of the information that we have about a patient, and some of that information is based on observation to answer the questions about the patient. The tool does not say that we are required to perform each task in order to answer the questions. So for example, on the basic mobility inpatient short form, one of the questions is climbing 3 to 5 stairs with a railing. In order to score the AMPAC and generate a T-score and a raw score, you do not need to see your patient climb 3 to 5 stairs. You do have to be able to make an assessment based on everything that you know about how much help you think that person would need to be able to climb 3 to 5 stairs. So this is an important point when you're working with therapists who are often accustomed to being able to extrapolate information about function and capacity. When we start talking about using tools beyond therapy and having nurses also score the tools, it's important to make sure we're discussing the fact that this is a capacity measure and that we are using the knowledge that we have to be able to answer the questions. Now, when we start to get into the details of the inpatient short forms, there are a number of questions that come up in regard to the influence of things that happen in the hospital and how that influences scoring. So one of the first pieces of information for both the inpatient mobility and the daily activity short form is in regard to medical equipment. So in the hospital, patients are often attached to medical equipment. That when we're scoring the AMPAC short forms, moving that equipment does not influence scoring if the person only needs help to use that equipment. So if I have an IV pole and I need you to push my IV pole because I need my 2 hands on my walker to walk down the hallway, that I am not then negatively impacted by the fact that you pushed that IV pole. Okay, so we need to be thinking about what the patient is capable of if that medical equipment were not attached to them. When we start to look at the individual forms and we look at the inpatient mobility form, the short form, one of the questions refers to performing activities from a flat bed. So in the hospital, most patients have bed rails and the head of bed is often elevated. That isn't necessarily what patients experience when they leave the hospital. And we're trying to understand how patients are able to function. And so we have a couple of options as clinicians. One, we could ask the patient to perform the task by lowering the bed rails and having them perform it. But remember, this tool is a tool of capacity. And so we could also use our clinical judgment. So based on everything else that happened in this session with this patient, what's my judgment about how well they would manage if the bed rails were down? Okay. The second area that comes up for both inpatient mobility, more for inpatient mobility than for daily activity, but it applies to both areas, is the issue of co-treats. So therapists at times co-treat patients, either PT-OT, 2 PTs, 2 OTs. The critical piece of information here is whether the presence of 2 therapists is required to complete the task. So if 2 therapists are required in order to be able to complete the task, then you should score that component as total. So if it takes 2 therapists to walk in the hospital room, then that would be total assist. The critical piece here is whether it requires the skill of the 2 therapists or whether it's more convenient and efficient to have 2 therapists, because we don't want to penalize the patient if it's not a lack of capacity on their part. So it's important to delineate what's the role of the 2 therapists in the room. So let's shift to talking about the inpatient daily activity form. There are some rules about which parts of the activities are included in your scoring. So for the questions that are related to dressing and personal grooming, scoring is not impacted by retrieving items and setting up the environment. So for these 2 activities, if the therapist, nurse, family member brings all of the activities to the bedside and the patient then sits bedside and performs the activity, you are scoring based on their performance once those tools are within their reach. Toileting is impacted by managing clothing and performance of hygiene. So it's important when you're teaching or educating about use of the tool that we're talking through the rules and we're talking through how they impact the scoring. Because you can see that if you have a group of therapists who are including retrieval and setup into their scoring, their scores are going to be different. We don't want that because we need the strength of the tool to be able to help us talk about patients in a variety of settings. So the next area that comes up are, again, we're talking about medical devices. And for daily activity, this relates more to medical devices that are replacing activities. So feeding tubes and catheters. And so for this one, what we need to think of is when these devices are replacing an activity because of a lack of ability, then the patient should be scored as a total assist. Now, it's important to remember that you're scoring the patient in that moment in time. And if those devices are removed tomorrow or the next day, then I think it's appropriate to score the tool again, and you would see improvement in their function, in their capacity. So let's talk about some clinical implications for how can we use the inpatient short form scores in the acute care setting. So one clinical application would be care planning. So at our facility, we use the AMPAC to triage caseload and to think about aligning therapists to the patients who need us the most. So one way to do that is to think about what we refer to as choosing wisely. So can we think about using an AMPAC score to guide whether therapists need to intervene in an acute care setting? And what we were able to do is work with our neurology team to look at patients who nurses completed the AMPAC, and when the patient scored the highest possible score on the inpatient short forms, those patients were held and discussed, and we needed to determine whether it was appropriate for us to do an intervention. What happened was that we were able to repurpose our therapist and move them to the patients who were more impaired So the strength of having that information from the nurses allowed us to align the therapist to the patients with the highest need. Another area to consider is discharge planning. So how can we use these scores to help us in discharge planning? Now remember, discharge planning is a complex task that requires lots of pieces of information, right? I am not saying that a single score on the AMPAC activity or mobility or cognition, applied cognitive, should automatically mean that a patient is placed in a specific discharge location. What we want to use the information for is one more layer of information to guide us in that decision making. And so that has been very helpful when we think about junior therapists who are learning to make discharge recommendations, or communication with social work and case management, or at least identifying that placement might be an option on a trajectory so that we can plan for that a little bit earlier. So in work done by Drs. Young and Hoyer, they were able to look at patients who had AMPAC scores within 48 hours of hospital admission. And those patients who tended to be older with lower mobility scores were more likely to be discharged to a post-acute care facility. So you'll notice that we're not saying a specific score, but we are saying that the lower the mobility and the older the patient, the more likely there's a post-acute care facility as a discharge option. Dr. Jette worked with Cleveland Clinic, and they looked at T-score cutoffs for mobility and activity for where's that decision between home versus institution, and came up with the T-scores that you see on the screen as indicators for this sort of line that would most frequently indicate when a patient would go home versus an institution. Again, not saying that that score is an automatic institution admission versus a home admission, but rather another piece of information that helps sort of guide that decision making. So application of the inpatient short form it's a couple of pieces. Is that it's important that you're ensuring that your clinicians and your staff are reviewing the scoring rules, that there's provided education, and that there's consistency in how the tool is being deployed and scored, so that you can then use the T-scores to help with care planning and discharge planning for your facility.
Okay, thank you, Annette. I'm just going to, I've just put my camera back on again. So, and we've had a few questions come up that I hope that either Annette or Dr. Jette would be able to respond to. If you have any questions, then please pop them in the chat, and we've got time to sort of address all the questions that come through, I would hope today. So there's a couple of ones that have come through first, and I think this one is possibly one for Dr. Jette, which is the question asks, how trustworthy is the AMPAC short form? And I think this question came up when you were talking around the difference between the CAT version and then the short version. So, you know, how does the CAT version differ, and how trustworthy is the short form in that sort of comparison, if that makes sense? Are you able to take that question?
Yes, absolutely. Happy to take it. I'll respond to it in two ways. One, in general, about trustworthiness, and then secondly, in comparing the CAT to the short forms. We have done research over the past 15 years on the general trustworthiness of collecting functional information from the AM-PAC. And we've published a series of articles looking at the consistency of scores and the validity of scores generated when one uses the AM-PAC with different kinds of patient populations and in different settings. And we found it to be highly reliable and highly valid. And if you're interested in looking at the series of articles that we've published, you can go on the AM-PAC website, and there's a drop-down menu that lists all the publications over the past 15 or so years, and that's am-pac.com. In terms of comparing the trustworthiness of short forms versus the CAT, we've also done research where we've done direct comparisons of the CAT versus the short forms. For the most part, the short forms, if used appropriately, will very closely approximate the scores that you would get from using the CAT. You do give up some precision using a short form, particularly for patients who are at either the low end or the high end of the functional difficulty continuum. So you do give up a little bit because you've pre-selected the items, in contrast to the CAT, which is selecting the items in real time based on the response from a particular patient.
Excellent. Thank you, Dr. Jette. Another question, and this one may be for Annette. Does it make it invalid if you use modified AMPAC language? For example, do you have to use the original language for the acute care side, or can you use modified language? And I'm guessing Annette, but if not, Annette, please say if you think it's one for Dr. Jette.
So I can speak to it, but Dr. Jette may also have an opinion. I assume you're meaning, can we modify the wording in the question? And it's a standardized assessment, and those are standardized questions. And so we should not be modifying the questions. We should be answering them as they are written. It's important that way we maintain the psychometrics of the tool. Dr. Jette, do you want to add to that?
No, I would agree totally with what you just said, Annette.
Excellent, thank you. Okay, another question, and I think this one would be for Dr. Jette, is are there any plans for a pediatric version that you are aware of? Is that one you can speak to?
I can, and I think Annette can also. First of all, let me say, in all of our development work, our patients that we included in our development research were aged 18 or older. But we have gotten the question from people over the years of whether or not it can be used for younger populations. And I believe our colleagues at Johns Hopkins have been investigating this. Annette, can you speak to that? Is that a correct assumption on my part?
There is a group here that is working on looking at whether the short forms are appropriate for pediatric patients. They're currently investigating that, so I don't have more information.
Okay, great, thank you. Another one, and again, this one might be for Annette. Does administration of ICU meds like vasopressors or inotropes impact scoring? Meaning patients in ICU may well not be able to walk without certain continuous IV meds, but can do limited walking with continuous IV meds. Does that make sense? Are you able to speak to that one?
So I'm hesitating because I'm thinking. So sorry. I think it's important to answer the question the way it is written. And so if the patient is able to walk in the hospital room, how much help from another person does the patient need to walk in the hospital room? That is how I would answer the question. I think the influence of the medications depends on what happens. I'll stop there. I'll let Dr. Jette speak.
Yeah, it's a really good question.
Yeah.
I do agree with the way that you answered it, Annette. If someone is taking a medication and you're scoring their ability at that time, then I would score their ability, the way in which they're currently taking medication. And if that changes over time, then it may influence the amount of help that they require. It would be the same way with, say, with someone with Parkinson's. When they're on meds versus off meds, it's going to influence their function. And so at the point that you do the assessment, I think you should rate their ability at that point.
Great, thank you very much. We've had a few questions, and I'm just going to take this one for a minute. A few questions around purchasing AMPAC, and this is a CE webinar, and I don't want to talk too much about purchasing and things like that, because it's not intended to be a sales webinar, but I think it's useful just to explain to people how they obtain it and use it within their organization. And I did have a couple of slides in here in sort of preparation in case this came up, so it's probably a good point for me to mention this now. So there is when you do, sorry, I'll come back to this slide in a minute, that's for your CEs, which I'll mention at the end. So for using AMPAC within your organization, you purchase a license to it, a 1-year license to be able to use AMPAC within your organization. And when you purchase that, you get delivered a PDF with all the relevant forms, all the short forms in there, and all the different options of the forms. In fact, the next slide explains the different forms in here. So there's the inpatient, the home care, the low function forms, the outpatient forms, and then the basic mobility and community mobility surgical forms. So, and you can see on this slide here, they cover mobility, daily activity, and applied cognitive and the inpatient, the low function forms, for example, don't cover applied cognitive, but you get all those forms within the pack. So the order process is basically you download an order form from our website. The license is $189 per year, and you can use that within your hospital site. So if you have 7 hospital sites, you would need 7 licenses, for example. And then you get, you're able to use that however you want to use it within your organization, whether you reproduce the paper forms, whether you build the paper forms into your own EHR system. So I thought I'd mention that now because a couple of questions have come up around that. So, but if you do have other questions, then please do reach out to me on that, and I will be able to address those as well. So if I just go back a minute, and I'm going to leave up on here my contact details in case people do need them. But there's another few questions come up as well whilst I've been speaking. So I'm going to ask these now. So one question, and this is probably one for Dr. Jette, is do we plan to translate, for example, French? And I think this one's specifically French-Canadian. Do we have any French translations or have any plans around that you're aware of?
Yeah, that's a good question. I don't know. The honest answer is I don't know if there's been a French-Canadian translation of the AM-PAC. You can reach out to me after the presentation, and I can look into it with my colleagues to see if we're aware of a translation. And if we aren't aware of one, and if you're interested in doing so, also reach out to me, and we can talk about that.
Excellent, thank you. And my details are on the screen as well, so people can contact and reach out to you via my details on the screen. So another question, please discuss the low functioning acute care short form, what items it includes and the benefits of it versus the 6 clicks version. Is this something you can speak to, Dr. Jette?
I can, yes. Again, it's a good question. Colleagues, as they have begun using the AM-PAC in the acute care institution, have discovered that the original version of the 6 clicks acute care form on occasion raised problems when used with very low functioning patients, particularly those in the ICU. And so we did a study with our colleagues at Johns Hopkins and at the University of Pittsburgh Medical Center, and we developed, working with clinicians in both of those institutions, some new items that would focus on very low-level functional tasks that are important for patients, for example, who are in the ICU. And so we expanded the acute care short form by adding 2 items that were very low functioning to the original 6 clicks, both the mobility and the daily activity form. And the advantage of that revised short form is that it allows you to estimate very low level functioning of these patients in a way that's a little more precise than it would be in just using the original 6 clicks. And so you are able to characterize low level functioning better than if you just use the original 6 clicks. And again, by incorporating it into the original instrument, the standard score that is generated is on the same metric as all the other short forms. So you get additional precision at very low levels of functioning, and you still can use the same metric with other short forms.
And I can just add to that from a operational standpoint that we have deployed the low function AMPAC in our ICU settings, and it's allowed us to be able to monitor progress of patients in the ICU, and then as they step down to the floors and we transition to the inpatient 6 clicks forms, because we have the T-scores, we can continue to track patients' progress as they change across those 2 settings.
Excellent.
This is a perfect example of why converting raw scores on a particular short form to a standard score is so important, exactly as Annette has illustrated. You can't compare raw scores from one short form to the other, but you can with standard T-scores.
Perfect. Thank you very much. Another question that's come up, and I think this is related to one of the slides that Annette was talking about, and it says, can you clarify that if 2 people are required for mobility, then the proper score is total assist, not a lot of assist? Are you able to clarify that score? Does that make sense?
It does. In fact, the scoring rule is that if 2 people are required for mobility, the score is total.
Excellent. Okay, that was an easy one to answer. Okay, another couple of questions. So are there, and I think this one might be for Dr. Jette, are there functional stages for AMPAC 6 clicks daily activity that are sort of cut-off scores to support discharge recommendations? So are there levels of scores that would support sort of discharge recommendations, such as, you know, perhaps a rehab facility or a home facility, for example? Are you able to speak to that?
There is some literature, and I think Annette used one of the articles to show the scores for the mobility and the daily activity short forms that were related to institutional versus home discharge. Is that right, Annette, in one of your slides?
Yes, that's correct. I can go back.
And so that would be an example, and that's the one I'm most familiar with. That came from an article published by Diane Jette et al. In the journal Physical Therapy on discharge planning. And there may be a few others. I think Danny Young may have published an article looking at some cutoffs as well. This is where it would be useful for people to take a look at some of the literature if you're looking for specific clinical applications.
Excellent. Is it worth it? I'm just looking for that slide as well, Annette. Can you remember which one it was? Are we able to get it back on here?
Take us back. It's right here, and the references are on the slide.
Perfect. Thank you. Thank you. Okay. Another question that's come up. What are the 2 additional items for the lower functioning patients in acute? Does that?
Annette, do you remember the 2? I forget the 2 items.
Yes, I actually just looked them up. So the 2 items are how much help from another person does the patient need, turning your head toward a sound, and following simple instructions.
Wonderful,
And
thank you.
They were co-calibrated to the original scale. So they're added to the 6 clicks short form. And by doing that, we had to generate a new conversion table, both of which are in the AM-PAC short form manual.
Oh, okay, I'm trying to speak and I was muted then, but thank you very much. Okay, let's I've just closed down the question box to see if there's anything else that's just come up. Okay, so I've got another couple here. A couple of people have asked, are we sharing about the handouts? The PDF is available, the handouts. If you haven't located that, it should be underneath the chat box where you can download the documents from the session. So just to mention that, because a couple of people had asked about that. And a couple of people who may have missed it at the beginning. Will we have access to the slides afterwards to be able to look back so we can review with colleagues? Yes, you will be able to use your logins for this session to be able to view this recording 30 minutes after the session, but it will also be available without a login on our website, probably from next week sometime. So you'll be able to direct colleagues to it as well. So another question, and I think this one may be for Dr. Jette. Are you going to come up with an app-based form? Are there any plans for that you're aware of?
I think some users have developed apps in their own institutions. We have not. We don't currently have a particular app that uses any of the short forms, nor do we currently have plans to do so.
Great, thank you very much. And then, I think we've answered that one. And sorry, I'm just looking through to see if there's anything else that's come up. And I think we're probably almost at the end of the questions. If anyone's got any more they want to throw in the chat, then it's your last chance to be able to do that. Here, we've done the app one, done the slides. Oh, here's one as well that I wonder if Dr. Jette could address. Has AMPAC been used to evaluate function in patients with progressive decline, such as dementia? Are you aware of any usage in that field? And maybe Annette can address that one as well. I'm not sure who will be best placed.
Yeah, it's again a very good question. I am not aware of any specific applications for people with dementia. Obviously, you would have to use proxy assessments. It wasn't designed for that particular patient population, so I think one would have to investigate that. I think it certainly would be possible using proxy assessment, but I am not aware of any group that I could point to. Annette may know.
I don't know of any group either, Dr. Jette.
Okay, great. Thank you very much. Another one, are we aware of any studies or correlation with risk for falls as well? And again, Dr. Jette is probably the first person I go to for that question.
I think there is some literature that looks at function and risk of falls. Off the top of my head, I can't quote the reference, but I think, there is an existing literature on function and risk of falls. Whether or not the AM-PAC has been used, I can't tell you precisely, but I can look into that if someone wants to drop me a note. By the way, if anyone wants to reach out to me, it's Alan M. Jette, one word, ALANMJETTE @gmail. But I can look into that. I can't quote something off the top of my head.
Totally understood. That's fine. Another question that's come up, and I'll just respond to this one, is will anyone be able or allowed to translate these forms? There's usually a process for these regarding permission and things like that. And what I would say is reach out to Dr. Jette or myself, and we'll be able to sort of point you in the right direction if you want to be able to do that. So it's kind of there's no sort of yes, no answer to that question. So I think it's better that you reach out to us separately on that. And I think that's all the questions that we've had. I'm going to pause we've only got 3 minutes left anyway, so it's probably a good point just to pause to see if there are any other questions that anybody wants to put in the chat. Now is your sort of last chance to be able to do that. And I'm sort of hesitating and pausing, giving people a chance to do that if that's the case. Whilst I'm doing that, actually, while I remember, I need to mention this slide anyway. For those of you who joined the session late, these are your instructions. I said these at the beginning of the session, but these are your instructions for submitting the forms for AOTA CEs. If you are a physical therapist, you can still get a certificate of attendance by completing our evaluation form. For an occupational therapist, if you want to get AOTA CEs, then complete the evaluation form. If there's more than one of you at your site, then please attend the attendance sheet. Please complete the attendance sheet and send that in to Darlene Davis, whose details are on the screen. We will only provide CEs if you attend the whole session, the live session. For anyone watching this afterwards, a recording, then you won't be eligible for CEs for that. And whilst I was reading that, there was one more question that came up, and I just thought I'll quickly mention it, is, are there any plans for any forms that would be used for teletherapy or telepractice? I'm not aware of anything, but again, a last sort of answer from Annette or Dr. Jette, any awareness of the use for telepractice or teletherapy or telehealth?
I'm not aware of any specific application for telehealth. I see no reason why one could not do it that way, but we have not in our group investigated it as such.
Okay, wonderful. All right, I see we only have about a minute left. So on that note, before this cuts us off, I'm going to say thank you to Dr. Jette and Annette for presenting today. It was a really useful session, really good opportunity to ask these questions of experts on the AMPAC. So thank you everybody for attending. You should be able to access this 30 minutes afterwards if you need to access again. And I wish everybody a good day. Thank you very much. Bye-bye.
Thank you.
Thank you.